All right, let's talk about patellar tendinopathy. So, there's some key principles that have recently been elucidated by the work of Dr. Keith Barr in his lab at UC Davis. And particularly when we're talking about bone patellar bone or postoperative ACL, right? You're going to get a lot of donor site morbidity is a common issue because they literally just take a section out of the tendon. So you can, a lot of patients and a lot of providers will simply just put up with it. They'll load through it. They'll push through it with the expectation that this is going to be a thing. But the truth of the matter is that historically we have focused predominantly on the donut rather than the whole. Okay, so here is what is put out by Joel and other tendon experts, we'll say. Historically, we focused on the fact that there's a degenerative portion within the tendon. In fact, if you look on ultrasound and if you pigment it, you can see that degeneration. And what they have shown is that that doesn't really change. It remains degenerative. And when you get a reactive tendon, that's where the viable tissues have started to acquire the stress and have become into a state of homeostasis where they're overactive or overused without adequate rest or recuperation. And so the thought being would be if you can thicken the tendon, thus you focus on the donut rather than the whole, was the saying, then you could have the percentage wise, you could have a higher viable tendon because the viable tissue would be a greater percentage relative to the degenerative portion. Yet you needed to be careful as to where someone came in at. If they were in a reactive or acute state, then trying to work on their donut would not go well because that portion of the tendon was already reactive and you would have to use acute modalities in management otherwise to calm it down. Right. Well, with Keith Barr's work, he started to challenge that notion such that he uses he's a wonderful teacher and instructor, and he's also very entertaining, and he talks about being from Canada and the fact that they love donut holes and that we need to fill that in. And so his recommendation on how we go about filling that in is not to enter the rhetoric or the debate as to whether we're going to use eccentrics or concentrics or isometrics and which one's superior. In fact, he's going to unanimously recommend, at least for starters, if our goal is really to fill in the whole of the donut, is to use isometrics. And we need, in order to understand how this works, we're going to need to talk about the viscoelastic properties of tendons. And when we use terms such as viscoelastic properties, sometimes it's not intuitive. It certainly wasn't to myself. But this analogy certainly has helped, this visual has certainly helped me, right? So you have stress on the y-axis and you have time here. And then if you have the application of constant deformation or as shown by the line. So think about the viscoelastic properties of water. That's something I was a little bit more familiar with, and so the analogy works. So if I do a belly flop, then essentially there's a high stress moment, right? The hydrogen bonds of the surface of the water don't have time to actually relax, and thus my body acquires a lot of the force, and that's why if you jump from a 30-foot pool or 30-foot diving pool board into a pool, right? It's even greater because you are it's higher stress in a reduced time capacity. However, if you were to gently just like dive into the pool or slip in, because it takes a shorter amount of time, and the viscoelastic properties of the water allow your body, they essentially have a stress relaxation, allowing your body to then slip into the water without enduring that high stress. So that is, in essence, kind of the stress relaxation component in viscoelastic materials, and tendons have a similar component of property of viscoelasticity. So the example that he shows here, so you have the deformation and you have time, similar to what we saw above, right? So if we have a quick onset of contraction, so if you quickly stiffen your tendon or contract your muscle or try and do in this case it would be like a knee extension against say an isometric, and you had someone rapidly extend their knee, then you would get this quick deformation, and then you have them reduce their force, right? So it would be a quick pulse. So let's look at our degenerative tendon here. So we'll imagine that this is our patella tendon from our story above. Okay. So as you get that quick impulse, there's like this protective nature where the tissues don't have the opportunity to relax and everything stress stiffens, and these red lines indicate the propagation of force through the tendon, where it goes around and circumvents the tendon, or the degenerative portion of the tendon. Now this is good because, like, if we wanted our bodies to be protective, and say we needed to, run, even in the presence of being injured, such as like survival, etc., then that's a good mechanism. However, it doesn't really help us when the science of mechanobiology suggests that the degenerative portion needs to feel the force of mechanical tension, because that is the stimulus for adaptation. So if instead of just having a quick impulse, an onset of force, if I have a gradual onset of force that's sustained over time, right, as in the black line, and then you see the green line, that over time there's this stress relaxation that occurs, such that if I sustain that force on the tendon, then the outer portion, the viable tendon, or tenocytes, if you will then relax. And as they relax, then the force starts to penetrate the donut, penetrate the whole of the donut, right? And this is important because that promotes tendon remodeling. And as you start to load that tendon over and over again, the human biology would suggest that it's going to adapt to the specificity of imposed demands, and given the optimal dosage, frequency, as well as the building blocks, which we'll talk about here in a moment, well, then you're going to get a filling in of the donut hole. So that is essentially why doing dynamic loading, such as anything from the form of isotonics to eccentrics to concentric, etc., though they can help fill in the viability of the tendon, they would fall short of being able to fill in the donut hole. And if we're looking so let's get a little bit more specifics about our parameters now that we know that we need to have this relaxation. So 100% of the relaxation, I believe, occurs around 3 minutes, according to Keith Barr's work. However, 45% of the stress relaxation occurs within the first 30 seconds. So we're going to bias ourselves towards holding for more pragmatic durations of time. Like, you get a disproportionate amount of relaxation within that first 30 to 60 seconds than you do over if you were going to hold it for 3 minutes. You would get marginal return on investment as far as your time and effort. Additionally, because we need high intensity contractions for tendons to respond, it would be very difficult and nearly impossible to sustain said high intensity contractions over 3 minutes. So the regimen has previously been touted around 5 bouts of about 45 to 60 seconds. Starting at about 30 seconds would be a minimal, because if you do anything less than that, then the amount of stress relaxation that you get of the surrounding tissue is not as grand, and thus the penetration into the tissue that needs to be remodeled is less. This also the other thing that matters is how you contract. So if ideally you want to have a slow ramp up of contraction. Why? Because it's the same concept as what we talked about with the swimming pool. That if you have a slow onset of contraction, then things don't have the means of stress stiffening, and thus you may get a better stress relaxation and a more homogeneous force distribution through the tendon. Okay, we spoke about the duration of time being about anywhere between 30 and 60 seconds. 45 seconds being kind of that sweet spot. Let's talk about the number of repetitions and dosage. So essentially what is shown here is an enzyme within the tendon that shows the remodeling. Across the x-axis you have time. So what they've done here is that they've essentially done they've taken little graphs of ACLs that have come off, I think, injured skiers, as the story is told, and they attach them to these small machines that do cyclic loading and then look at the gene expression, right? And so what they show is that even though you stimulate the connective tissue, the ligament, for extended periods of time, up to an 8-hour continuously, is that really you get what is called a signal saturation, where it drops off thereafter, right? And thus you don't really get any addition, right? If we're trying to have what is a minimal effective dose, going up to 15 minutes and no more is important. So this has implications on our dosage. It also has implications on where it occurs within our rehab. Because if we look at the recovery time, so now instead of minutes, you're looking at hours. So they continue to stimulate the tendon, the ligament again and again, and it doesn't start to respond again until about 6 hours. So if you were to prescribe someone, like for instance, historically they've done continuous passive motion, right? It doesn't really hold up as far as our science is concerned when it comes to collagen remodeling. And you can show the loading intervention here. No loading, continuous loading, or intermittent every 6 hours. And it's clear that the collagen and the percent of dry mass significantly increases. Continuous is certainly better than doing nothing, but it's only 50% of what would be intermittent. Now, keep in mind that collagen synthesis, depending on the insult, right, you get a degeneration of connective tissue and muscle tissue over the course of a bout of exercise. Okay, so specifically if we consider this, so you could hypothetically, depending on the intensity and how much stimulus you give it within this 15 minutes, you could re-stimulate the tendon every 6 hours. Now, for a range of motion standpoint, perhaps that's helpful for your collagen, but we also know that collagen synthesis in tendon can look something like this, right? This is from a different source. It's from Schlepp and Muller in 2012, right? Where you have the stimulus, which is exercise, which is your tendon loading. Then you have your there's degeneration of the collagen. There's also simultaneously synthesis, but you're still in this net degenerative component. And if we talk about the general adaptation principle, right? If we consistently hit our tissues when they're in this net negative, then we will likely have a progressive degeneration, potentially putting us more into a reactive tendon state rather than a viable tendon state. So it would be ideal that, yes, you could theoretically hit it every 6 hours and it would respond, but you also have to consider like what the state of the tendon is and how acute and irritable it is, right? So if I was to dose my exercises specifically, I would be wanting isometrics because I want to fill in my hole. I would want to be doing it for a minimum of 45 seconds. I would want to be doing it early in my exercise bout of the day, or separated by 6 hours from my other exercises, such that I'm not getting a signal saturation. Like if I did it at the end of an hour workout, I probably wouldn't get as much bang for my buck because the cell signaling is otherwise silent within the tendon. I probably would want to do it for no more than 10 to 15 minutes, just because of diminishing responses, right? And if I was to program it across a week, if it was like a submaximal load and there wasn't too much degeneration within the collagen fibers of the tendon, well, then I could potentially do it every 24 hours. And certainly RCTs and some of the biggest names in tendon research would suggest that you could do it up to 7 days a week. Great. I find that doing it 5 days a week with potentially 2 days on, 1 day off, and cycling that has been a more pragmatic approach. I don't know what is the best, but from a clinical standpoint, that is my perspective, is that it's just a lot to ask for people to be able to do it every day, and certainly every 6 hours if they're doing a maximal effort. And not to suggest that there's central fatigue and muscular fatigue, and just the practicality of that is also put into question. So whether you want to do it every day, whether you want to do it every 6 hours, I think would be dependent upon your intensity. As I alluded before, we need about 70% of 1 rep max for tendons to respond. That being said, if someone is in an acute state and they can't tolerate that, obviously we know that some is better than none, right? So even if you're doing it submaximally, it would be optimal. So when we're going back to our case example as to when we're trying to take care of this tendon morbidity, you could continue to follow your standardized protocols and continue to just expect natural history progression to take its time and just say this is the way that it is for tendons to be, your patella tendon and your donor site to be tender and sore and painful. Or we could potentially take a more pragmatic approach and actually try and, one, ensure that we're not in a reactive state. Certainly loading with your eccentrics and your concentrics and your tempo-controlled resistance training would be viable for the overall healthy tissue. But if it is if there's degeneration, which we know that there's a hole in it because it's actually been grafted from that, well then isometrics have got to be a component. The final thing that I would leave you with would be considering the supplementation or the nutrition, the building blocks that I alluded to. So substances or forms of protein that are high in glycine and proline have shown to have positive benefits when it comes to collagen synthesis. So kind of a busy graph, busier than the other ones that we've seen, but essentially you're looking at glycine micromoles per liter within the blood, and then you're looking at the different sources shown here. And then same thing for leucine, and you can see that in this case it was a hydrolyzed casein. It was a milk protein. Here the yellow showing the gelatin. Also hydrolyzed collagen peptides. However, they need to be taken with at least 50 milligrams of vitamin C for better viability. That we know that this can, compared to controls, would actually help by increasing the collagen synthesis by over 200%, which is certainly encouraging. And they should be taken about 30 to 60 minutes prior to our loading, because this is where the bolus is induced, and this is the time where the blood circulation of the glycine is at its highest. And then the mechanical loading can act as signaling for where the body needs to put the collagen and the amino acids. So I hope that helps to kind of clarify why you may want to consider isometrics within your tendon remodeling and your rehab.